আপনাদেরকে দেখতে পাচ্ছি না, আপনাদেরকে দেখতে পাচ্ছি না। আজম, আমরা তো কমিউনিকেট করতে পারছি না ক্যাটল্যাবের সাথে।
স্যার, ওনারা খুব শীঘ্রই আবার জয়েন করছেন আমাদের সাথে, হয়তো আর 1 মিনিট লাগবে।
ওকে ওকে ওকে।
স্যার দেখুন তো স্যারদের সাথে কথা বলে শুনতে পাচ্ছে কিনা স্যার।
আমি শুনতে পাচ্ছি। ধীমানদা,
মাসুদ ভাই, আপনি আমার কথা শুনতে পাচ্ছেন?
ক্যাটল্যাবে শোনা যায়?
হ্যালো, মাসুদ ভাই শুনতে পাচ্ছেন?
স্যার শুনতে পাচ্ছেন?
হ্যালো,
আমি শুনতে পাচ্ছি, হ্যাঁ।
ডক্টর অশোক শুনতে পাচ্ছেন?
হ্যাঁ, শুনতে পাচ্ছি। ধীমানদা, আপনাকে দেখতে পাচ্ছি না। আই ক্যান হিয়ার ইউ বাট আই ক্যান নট সি ইউ। Yes, now I can see you. You are visible now. Yes. আফসার সাহেব, আমরা কি শুরু করব এখন?
হ্যাঁ স্যার, আমরা শুরু করতে পারি।
Okay. So, good evening, everybody. Today, our Heart Foundation cardiac course for postgraduate student. Our topic is transfemoral angiogram and assessment of coronary artery disease. Angiographic assessment of coronary artery disease. Our operator is Dr. Dhiman Bonik. He is the Associate Professor and Senior Consultant, National Heart Foundation. In-house moderator, Dr. Shamim Chaudhary. He is the registrar of our hospital. And we have expert panel on examiner's perspective, Professor M.G. Ajam. He is the Professor of Cardiology and great interventional cardiologist in ICBD. And definitively his advice and his opinion and comment will be very much helpful for our students. And today's moderator is Dr. Tawfiq Shariar Haq. For the time being, just I am doing try to do his job. So Dr. Dhiman Bonik, we can start with femoral angiogram first.
Okay, thank you, respected teachers, colleagues, and friends. It is a great privilege for us, for me also, to show the femoral angiogram and the angiographic assessment of coronary artery disease. And now I'll request my co-operator, Dr. Shamim, registered National Heart Foundation, to say something and give the clinical features of the patient lying in the coronary angiogram table.
Respected teachers, honorable panel of experts, moderator, Assalamu alaikum. Our patient, Mr. Y, is 37 years old, diabetic, non-hypertensive, non-smoker with a positive family history. He is a known patient of old MI anterior 1 month back, and he was managed with conservatively with low molecular weight heparin. His ejection fraction is around 40% with regional wall motion abnormality present, and all other parameters are normal.
So MI anterior ejection fraction 40%.
Ejection fraction is 40%.
Yes.
He is smoker, young patient, and we decided to do the coronary angiogram of this patient in femoral approach.
Yes.
We have done the puncture as it was late. So we dragged the patient after giving the antiseptic wash of this patient with antiseptic solution on the both groin, and we have the right femoral approach of this patient. Before starting the intervention area, I want to say something about the anatomical landmark of the femoral artery in the groin area. A femoral artery is the continuation of the external iliac artery after giving the inferior epigastric branch. And at the upper part of the thigh, it divided into a superficial femoral and profundus femoral artery. And this mid portion below the epigastric artery and the bifurcation of the profundus is the main area of the puncture for the femoral artery. And it is the mid part of the, it is choice of the puncture of the femoral artery is the mid part of the femoral artery, as because this mid part lies above, just above the head of the femur. And this area is demarcated by the 3 to 4 centimeter below the inguinal ligament, not the crease of the groin. You should, the student should have know this. This is not the crease of the groin, but it is the inguinal ligament, 3 to 4 centimeter below the inguinal ligament. And after giving local anesthesia with 2% lignocaine without adrenaline, in the books it is written that adrenaline lignocaine should be 1%, but we give the 2%. So after taking 2%, we made it 1% by we take around 5 to 7 ml of 2% lignocaine and dissolve it in 5 to 7% of normal saline. Then it becomes 1% lignocaine. And we then give local in the palpated femoral artery, and we go superficial, then we go into the deep part of the area of the pulmonary femoral artery puncture. We have a 16 gauge puncture needle. This is the puncture needle. It is the puncture needle. This puncture needle has a metallic portion and a plastic portion with half distal half, and we introduce this in between. The palpation is by the two fingers, and you can see below this inguinal ligament, my two fingers is there, and I have punctured this area, and it is the about 3 to 4 centimeter below the inguinal ligament, and I punctured this area, and I punctured it with a modified cell linear technique, and I then introduced the this is the short guide wire. This is the short J-tip short guide wire. The short guide wire had gone through this plastic portion of the needle easily. Then I introduced the vascular access sheet, 6 French vascular access sheet. It is green color, so it is the 6 French vascular access sheet. And by clockwise and counterclockwise rotation, I fire the skin, then the subcutaneous tissue, then I throw the where I entered into the femoral artery. And before that, I have a cut mark, small cut mark with this BP blade. The short around the skin around the short guide wire. And in the monitor, you can see the in the monitor you can see the guide wire, advancement of the guide wire. It is just middle of the femoral head. You can see it is just middle of the femoral head, and this thing is almost done appropriately, because if the patient is obese, some of operator do this puncture by not by palpation, but only by seeing the head of the femur, middle of the head of the femur, and this is almost the accurate space of the head of the femur, central part of the head of the femur, where the femoral artery lies. And the upper part, the femoral, you can you see the upper part? At the upper part, you can see the guide wire is in the middle of the vertebral column, which indicates that it is in the artery. For the students, this is very important. And if it is in the lateral part of the vertebra, on the right hand side, it will be femoral vein. So with this, this puncture is done. Then let's start the coronary. That is, time is short. Let's start the doing the angiogram. Any comments from the panelist and the moderator? We are advancing the guide wire to the abdominal aorta, to the ascending aorta, and to the ascending aorta. If you wire does not enter, pull back the wire. I just rotate the wire and counterclock rotation, and I think it is almost engaged into the left. The wire is going out, and I have taken this flush as because I want to clear the air inside the catheter. I have attached with the catheter with the manifold with the rotating, and I see the pressure. You can see the pressure wave. You can see the pressure. The pressure is 120 by 80. And I have taken the back flush in the catheter, and putting the air and the up, and I give a check to see where my catheter is, And I seen that this is close to the ostia. So I pull the catheter and with a slight rotation. And I think it is engaged. The catheter is moving to and fro. Yes, it is engaged. It is engaged in the, it is important for the student that catheter is engaged in the AP view. AP view, this is the AP view or a RAO with this shallow RAO view. It is the shallow RAO view, or it is the first shot. And in this view, later on we'll discuss, because then it is the shallow RAO. Then we come to the
Epicranial.
epicranial. It is the epicranial. You can see this is the epicranial view.
Epicranial is the view for LED.
Yes, epicranial is the view for the LED. So next view is to see the ostia of the left vein and the bifurcation of the LED and the LCX. This is the caudal view or the spider view. And these three views are classical. One of the next view which is classical is the allocranial view. As there is a lesion in the mid, go to allocranial. This is the allocranial view. Allocranial view, we'll discuss this later on. So with these views, I think so the left side is, lesion in the left side is almost well delineated. So I remove the catheter from the left main ostia.
Thank you, Dhimanda. So Dr. Tofik is online now. Just Tofik, would you please moderate the session?
Sir, thank you very much for filling in for me. Sir, you can also continue. We can together
Yes,
continue.
of course, I will share.
So Dhiman sir has two things to discuss, not only the femoral angiogram, but also assessing the severity of lesions.
Yes.
Regarding femoral angiogram, what about the puncture that is usually asked in the examination, Professor Ajum? Cell-Ninja technique, modified Cell-Ninja technique, single bore metallic needle or dual component needle. Sometimes it may be asked, yeah?
Yes, Dada, thank you. Actually, in exam, anything can be asked by any examiner, but there are some specific prediction to specific techniques or a specific indication, specific views also try to evaluate by examiners. Actually, how deeply our students are absorbed our educational contents. So it is very important. Actually, indication, contraindication, conventional things everybody knows, but in typically in examination settings, which view is preferred to see the proximal LAD like that, or if you think it is osteal left main disease, which view we should take first? If you clinically think it is a left main disease by the clinical scenario, this is the guidance, the which view, what precaution you should take in the coronary angiogram laboratories. These are the typical questions should be asked in the question. I think we will cover it by the procedure operating by Professor Divan Kumar. Divanda.
RCA, then we'll.
Yes, Divanda RCA.
হিমান
Tofik,
স্যার
uh,
তো হারাই গেল নাকি আবার?
Divanda ki offline.
আচ্ছা,
Anyway,
আমাদের
Tofik, you can discuss regarding the puncture technique and
yes, actually, every operator has his or her puncture technique. Someone goes by palpation, someone looks into the femoral head and punctures, someone goes a bit high, someone goes a bit low. So everyone has their own. And as a matter of fact, I would like to say, when we decide that in our country, when we decide that we want to become an interventional cardiologist, the first thing we learn is the femoral puncture, and from that very day, we probably follow someone or find our own technique. Initially, in our learning phase, we used to we did some cases with double wall puncture. Then we gradually developed our expertise, and now we are doing single wall puncture. We always try to do. And regarding every step, we are doing femoral angiogram, so many cases every day, everyone is doing, but every step can, if you are not careful and take it very casually, you can, every step can put you into trouble. You can create a groin hematoma. You can, if you are in a hurry, you push your short wire, you can make a dissection. If you're not sure where your short wire is and you put in your sheath, you can make a muscle or subcutaneous hematoma. If you are too fast and pushing your catheter ahead of your guide wire, you can do you can make aortic dissection. If you okay, so Dhiman sir is back with us. Sir, we missed the RCA part. Would you like to show us again how you hook the RCA? What are the
Yes,
precautions you
after in
always
the
take?
the RCA tip is in the right coronary sinus. I had rotated it clockwise catheter and give a check, and the ostia is not visible. I have not rotated totally because the last time there was a die hang, so I was just in the ostia, and this is the allocranial view, and you can see there is a conus branch at the separate conus branch origin, and pressure is damping, so I am come out of the RCA.
So sir, there are lots of tips in this RCA case. If you go one by one, uh, uh, in your first shot, you had an idea that probably RCA ostium was diseased, dye was hanging, so you disengaged. And next time when you engaged again, you were very careful, gradually rotating clockwise and trying to stay away from the ostium. But again, you engage in the ostium, and we can see there is some ostial disease, there is some distal segment disease. And when you saw there was pressure damping, so after every shot in the RCA, you have to go back to your pressure, and you must check whether the patient is getting hypotensive and bradycardic. Whenever sir saw that there was pressure damping, he took a counterclock rotation of his catheter and disengaged, as we noticed. These are very important tips. If you abruptly pull, and if you can injure the ostium. If you go clockwise, you can tear off the ostium. So these are the very important tips, and I believe Professor Ghulam Azam will agree. These are the tips the examiner will want to know from you. If you are a keen observer in the cath lab, only then you can answer these questions. So Professor Ghulam Azam, would you please comment?
yes, right. Tofik, you just rightly mentioned. Actually, if anyone very cautiously observe the critical procedure, then he can able to understand how to interpret the answer. So this is the important tips and tricks in case of engage in RCA. Once it is over engaged, then you just, if you rotate, then you just counter it. So it is the number
Yes.
one take home message. Number two, each and every time when you try to hook the RCA, then you always check the pressure. If pressure dumping or ventricularization, then you should be careful. Then you just, if you give a short check, if you see the catheter is engaged in the conus branch, don't push injection because it will turn into VT or VF. So you just pull it on a 2 millimeter, then you just check if the dye is okay. If dye is totally clear up, then you go for injection. If dye in the RCA territory or RCA vessels, you give injection, then patient will go for uh, down catastrophic. So this should be keeping in mind to prevent complications. And RCA sometimes, especially in femoral angiography, RCA sometimes difficult to cannulate, but you will get some additional advantage in radial. RCA sometimes it may be easily cannulate. In case of reverse is true. In case of if you go to try to sometimes face difficulty in engaging in left coronary artery, left main coronary artery by radially, but in femoral it is easy to engage in left coronary artery. So question is that actually which method or which approach is every center is preferred to practice, and operator choice, patient's perfect. In the exam purpose, actually you have to learn indication some conventional methods, but the special tips and tricks you can answer by your daily practice with your seniors and discussing with your peer colleagues. Then you can able to understand what are the techniques in our clinical practice we are facing, how to solve our problems.
Is Dhiman sir with us? Dhiman sir, can
Yes,
you hear
yes.
us?
Tawfiq,
Sir,
loud, please.
what is your comment about this femoral angiogram and engaging the right coronary catheter? What would you what message would you like to give?
Tawfiq, I can regarding
Sir,
the
স্যার শুনতে পাচ্ছেন এখন?
এখন শুনতে পাচ্ছি।
Sir, regarding engaging the right coronary artery in this specific case, what is your message to the students
Yes,
who are going to sit for the exam?
Yes, I was in the right sinus and I was rotating the artery, rotating towards the right aortic sinus. And in the first shot, you can see that after giving the check, the dye was hanging. I rotated the catheter counterclockwise and come to the ostia and take the view. When I see that the dye is cleared up, and I saw that the pressure has been damping, so I remove the catheter. Then I take another shot, which is aleocranial, by slowly manipulating the catheter at the ostia. At the you show me the second shot, second angiogram, second view. Yes, you can see I was just in the ostia of the RCA, and there is no pressure damping in this view.
Okay.
So calibrating the ostia of the RCA, it is very important. And if you, as I totally agree with Professor Ghulam Azam, that if you cannulate the coronary sinus, the coronal branch, then you should try to remove the catheter. Or if you are a very much confident operator, then you can counterclock rotated the catheter, and then you push the catheter downwards. That will engage the right side. It is the engagement of the right coronary from the coronal branch. But this should be, you must be too much confident about this, that you have come out from the conus branch and you push the catheter. Because if the conus branch is like this, it is separate origin, frequently the catheter will go to the conus branch.
Sir, how would you like to discuss the lesions, severity of the lesions in this case?
I want to first go to the left side. This is the I engage the catheter in the AP view. Then it is a shallow RO or a AP view. This is the first shot. This left main is normal. In this view, we see the left main and the proximal LAD and the proximal LCX. In this view, by eye estimation, please stick on this view. In this view, the other things that are important is the mid and distal LAD. Mid and distal LAD is well seen in this view, how the LAD curves into the apex. And in this view, we can see a lesion in the proximal LAD and in the proximal LCX, including the ostia of the LCX. This is the two significant lesion in the proximal LAD and the proximal LCX, including the ostia of the LCX, and giving the how the severity of this stenotic lesion can be given two ways nowadays. One way is if the lesion is less than 50%, we can say there is mild irregularities or mild coronary artery disease. And if the stenotic lesion is 50 to 70%, it is moderate coronary artery disease. And if it is more than 70% up to 95%, it is severe coronary artery disease. And then comes the total occlusion. And another is the eyeball estimation. Eyeball estimation, we see the eyeball estimation. It is a arithmetical eyeball estimation, because eyeball estimation is a cross-sectional view, because coronary artery is a four-dimensional organ, and we see the two-dimensional picture. And two-dimensional, there is a formula that the normal diameter in the normal portion is A, and the area of the stenotic lesion is the B. And if A minus V divided by A into 100, it gives the two-dimensional area, stenotic area of the lesion. If it is 50%, two-dimensional stenotic lesion is 50%, then cross-sectional area will be 70%. And it is in the recognized books such as Morton and Grossman. And if the lesion is, if the stenotic two-dimensional picture is 70%, then the lesion will be 80 to 90%. And if it 85%, it is around 95%. And if the stenotic area is 98%, it is almost totally or subtotal occlusion. And this is the estimation of the lesion. So with this, we can see that. Can you see the next view? It is the epicranial view. And in the epicranial view, you can clearly see that there is a proximal lesion in the LAD involving the two diagonals, ostia of the two diagonal. Proximal diagonal has a moderate lesion, and the the second one in the mid portion has a significant lesion. And next, there is a significant lesion with a thrombus, I think so, at the LAD, with the thrombus in the LAD. So it is a long segment lesion. It is a long segment lesion, two lesions at the proximal LAD, two lesion. And at the distal part, there is a TME flow. And can you run the view? You can see it is a TME 2 flow, because the non-infract LCX has a good flow, and the LAD, which is a strong, which is a significant proximal and mid lesion with a lucency in the mid part, indicating thrombus. There is a, it is the TME flow. So with this, can you add something, anyone our
Yes,
panelists
yes.
and moderators?
Yeah, that is that is very important, Dhiman, that TIMI flow. Here you can see distal vessel of the LAD is totally visualized, but that is delayed. If
Delayed,
you
yes. It is
compare with the LCX. So this is TIMI 2.
Two.
If it is not totally visualized, even after some time, then it is TIMI 1. And
One.
TIMI 0 is no flow.
No.
So this question, I think, frequently asked in the examination. Dr. Ajam?
Rightly. Actually, Tofik rightly mentioned how to assess severity of coronary disease lesion by coronary angiography. Number one thing, how you should first make comment whether it is single vessel, double vessel, triple vessel, or left main or left main equivalent, whatever you like. That is one of the parameter. Number two, how if you assess the single vessel, then the one nicely demonstrated how you calculate is by ocular reflex, oculostenotic reflex, or by your eye estimation, naked estimation. You can gauge, yes, it is a severe 90%, 70%, 80%, but it is very difficult to make comment, especially in borderline lesion like 60 to 70% cases or 50 to 60. Sometimes if you in that borderline case, you have to need clinical judgment as well as other additional investigation tool to make sure that it is a severe disease or not. Third things is whether there any thrombus or calcification in like that you should consider. So in this the simple things you should keep in mind how you answer your how you face your examiner. You know what you exactly want to know, then you can just make a comment like that. Yes, it is sir. Multi-vessel disease is much more severe than single vessel disease. If it is actually calcification thrombus, it is much more significant disease than without calcium or thrombus. So like that way you can answer in your exam. But it is important to make sure TIMI flow regarding TIMI flow, either it is TIMI 0, TIMI 1, TIMI 2, TIMI 3. If it is TIMI 0, then you have to understand whether the thrombus burden. So you have to go for you are inviting for another issues. So once you sit in the exam, you try to answer your own way, where you guide to your examiner, where you are confident that you can track them in that your own way.
Thank you.
So that is the best way to
Thank you.
overcome the exam setting. But in real life setting, you have to confident, you have to dedicated, you have to understand the real tips and tricks that you can able to success.
Dhiman sir, or the expert panelists, would you say this is a left main equivalent lesion?
Yes,
Or when will you say this is a
I was
left main
talking with
equivalent lesion?
Dr. Shamim. These are the left main equivalent. Left main equivalent is commonly asked in the examination. There is a proximal LAD and a proximal LCX lesion more than 70%. And this is called left main equivalent. It is for the students.
So
Yes.
Another
is there
thing,
any
Dhiman,
Yeah.
Dhiman,
Yes.
one thing, in this view, look at the left main also. In other views, the left main looked quite good. But here, if you look, the left main is almost the same size as the other vessels, right? So I would, maybe there is some degree of left main disease as well. I think we need some more views to really, I mean, this is definitely a left main equivalent, but is there some disease in the left main itself?
Yes, ma'am.
Yes, madam. Then there may be, because the vessel size is almost equal to the LAD.
Yeah, so it a left main. This is another thing students should remember. A left main will always be larger than the LAD. It has to be. But here, if we look at the healthy portion of the LAD, in some views it is looking almost the same size as the healthy part of the LAD. The LAD is very diffusely diseased, so it's difficult to identify a healthy segment. But did you take a spider view, Dhiman?
Yes, I have taken the spider view.
So what does it look in the spider view? Look at the left main. Can we zoom on the left main? And another thing, Dhiman, maybe for the students, we need to also teach them about Medina classification for bifurcations, right? So this would be a true bifurcation, right?
Yeah, this is a true bifurcation with
Yes.
1, 1, with 0, 0, 1.
The osteo of the LAD is free.
Osteo of the LAD is almost free.
It is after 5 millimeter. The lesion in some views appeared after 5 millimeters
Okay.
into the LAD. But
Tawfiq, in spider view, you can make comment within 5 millimeters. You can better to make comment arrow coronal view, then you can make it is 1 or 2 or 3.
And actually, we would maybe need some imaging to really delineate the severity in the left main, whether there is any disease in the left main, right?
yes,
Yes,
so
yes,
in
madam.
our future, madam, I believe we have plans to show
imaging
physiology
as
and
well.
imaging as well.
Yes.
So madam has brought up a very important issue, that is the diameter of the vessels. So it comes as madam has rightly said, left main will be bigger than LAD. At the same time, we should also keep in note whether LCX is dominant or RCA is dominant. So Dhiman sir, would you also say something about the dominance? And
Yes,
its
we have
importance?
taken the allocranial view. In the allocranial view, the LPDA is not from the LCX. So we're supposed to be, this is the case of right dominant. In the part of the right dominant, is with the RCA? Yes.
পরের ভিউটা দেখান স্যার, পরের ভিউটা
So only
The next view. Yes. PDA
so
is
this
from.
is right dominant.
yes.
This is right dominant.
This is.
Yes, I was just trying to say that in case of left dominant, LCX might be of a larger caliber than LAD.
Yes.
Sometimes, yes, most of the
Yes.
time. And another measurement, madam, sometimes may be asked, diameter of the left main equal to 2/3 of the LAD diameter plus LCX diameter.
Yes,
There is rough
Finest
estimation
law.
like this.
This is the finest law.
So, Dhiman sir, would you please say about what precautions we should take while doing an femoral angiogram? What precautions did you take, or the students should know they should take while doing an angiogram, femoral route?
Yes.
What complications might be there?
Doing
Very
a femoral angiogram, the precaution should be that the hemoglobin should be in normal range, and then investigation profile with an platelet count. We did platelet around 80, more than 80,000, and in books it is written somewhere you can do within 50,000 also. And doing if the creatinine is raised more than 1.8, it is this patient is a high risk patient, and we can do with a patient having fluid challenge, giving fluid and giving acetylcysteine and using low dye during the angiographic process, and the total count should be normal. And puncture, during the puncture, I have mentioned it in previously, it should be 3 to 4 centimeter below the inguinal ligament, and it is the mid portion of the femoral artery against the
head of the femur.
Against the head of the femur. And after the puncture, if the wire is not moved into the needle, so the needle is not in the lumen, and the needle should be pulled back, and it should be moved laterally or medially to again puncture the femoral artery. And
Yes.
one thing I have mentioned, Dr. Tawfiq, that the right way, if the patient is very obese, then fluoroscopic guide can help the patient. It is the mid portion of the femoral head, the wire had moved. I have punctured it through the palpatory method, but it is almost at the mid portion of the head of the femur. And if the artery is tortuous and the femoral sheet, the short guider is not going, Then we can take soft guide terimo wire, and we can give a long sheet. Normally, the sheet we use, this is a 6-plan sheet, and it is a size of 6 centimeter to, sheets are normally 6 centimeter to 35 centimeter, and long sheet which is present in our lab, it is about 35 centimeter long, and if the artery is tortuous, then we can use the long sheet which Dr. Shamim will be described later on, and this will help to manipulate the catheter in the tortuous vessel.
Dr. Tofik, students should remember that femoral puncture is done not only for angiogram and angioplasty, sometimes for peripheral vascular disease intervention, that is superficial femoral or popliteal or iliac vessel disease, we may have to puncture the femoral artery. In that case, the 3 ways that we should puncture: one is by palpation of the artery. Second, on Dhimanda was perfectly telling that angiographic guideline. And third one is ultrasonographic guidance. These 3 ways we can puncture the femoral, especially in difficult cases when there is peripheral vascular disease.
Also, sir, nowadays I can add, nowadays femoral artery is used in MICS cases. When surgeons are doing MICS, they put cannula in the femoral. So when you know you have a case, maybe as we always say, ASD, we know that this is not divisible. This patient will go for MICS surgery. In those cases, we keep the right femoral artery, try to not to puncture the right femoral, we go left femoral or radial.
Yeah.
So it just to make the surgeon's procedure easier, so they can cannulate the
right
femoral
side.
artery. This is now, as MICS is coming up, very popular in Bangladesh. I think the students should also know this. So
Either
Dr.
radial or on the left side.
Yes. So Dhiman sir, would you say when are there any specific situations when you want to go left femoral?
If in some specific situation, you have already mentioned one, MICS, and the other situation, if the patient has a femoral angiogram before, and there is a hematoma on the femoral, right femoral, and now the patient is ready for PCI through the left femoral. So this can be go through the left femoral, or there is peripheral vascular disease involving the external iliac, right external iliac, where the wire cannot be passed through. So we can go through the left femoral side.
Right.
And
So,
other on things sometimes may be asked if there is graft on the right femoral super SFA.
Yes, if there is graft on the right. Yes.
Sometimes it's also present. So Shamim, do you have a presentation?
Yes, I have a question to discuss before Shamim starts on. In the exam, there is a question that when the artery and vein punctured at the same time, commonly in the catheter, right heart catheter, or being in catheter, right and left heart catheter, which vein or artery should be punctured first?
Yes.
Is that the vein should be punctured first, and the vein wire in the vein should be kept. No sheet should be given. Then the puncture of the artery should be done, and first of all, the sheet in the vein artery should be given. Then the sheet in the vein should be given. This protects the spasm of the artery, and this prevents from the artery venous fistula. And during the sheet out, when there is 2 artery and vein puncture, first of all, everyone should remember that arterial sheet should be removed first, not 2 sheet simultaneously. Artery should be removed first, and there is hemostasis. Do the hemostasis, and then the vein should be, after the arterial hemostasis, then the vein should be removed, and this also prevents the artery venous fistula. So I now request the
Shamim.
Dr. Shamim
So this
to
is the classic
demonstrate
system. Yeah.
some of the instrument used here.
And another thing, Dhiman, I just, for a brief recap, sometimes, we are doing a PTCA and the junior doctor removes the sheet maybe 4 or 5 hours later. So my advice to them is that always give some local on the side before you take out the sheets, because
Yes,
it's
ma'am.
already quite a long time and sometimes it is very painful. So that is also mandatory, that when we remove sheets after some time, a few hours, some local has to be given, permission has to be taken, and only then the sheets should be removed. Otherwise, patient might go into vasovagal.
Yes, very frequently this happens. Patient went into vasovagal. Thank you, ma'am. This is very important issue.
Madam, this is very important. This is very important, and I have gone through the books doing this procedure. In the books, it is written that before puncturing the artery in the radial or in the femoral, you should mandatorily look to the ECG. That most they give the percentage around 20 to 30% patient goes to vasovagal shock during the puncture. So you should give the local properly, and you should continuous monitor the ECG in the monitor.
Okay, Shamim, please go ahead.
Sir, I don't have any PowerPoint presentation. There are some I will just discuss regarding some instruments. First of all, regarding the wear. There are 3 types of wear we usually use during the angiogram. Usually for introduction of the sheet, we use short guide wire that is around 35 to 50 centimeter long. And for coronary angiogram, the wire we use, that is the medium length wire, it is around 120 to 150 centimeter long. And there are some large wire, that is exchange wire. We can use these things for device or cardiac catheterization. And regarding the other instrument we use that is important for the students is the Judkin catheters, left and right Judkins. The left Judkin catheter has 3 arm and 3 curve. First, from the tip to the primary curve, there is the first arm, and from the primary curve to secondary curve, there is the second arm, and it decides the length of the catheter, size of the catheter. That is, we usually use 3.5 Judkins catheter for left-sided coronary angiogram, and in case of right Judkin catheter, there are 2 arm and 2 curve. Usually, the primary curve is same for the left and right, but the secondary curve is the more in case of left, around 180 degree, and around 30 degree in case of right Judkin catheter. That's all from me.
Okay, so Professor Gholam Azam, are you with us?
Yes, actually.
Okay, so we are almost at the end of the hour. Would you please give your closing remarks? Some points for the students.
First, I give special thanks to Dr. Dhiman Bonik and National Heart Foundation team to arrange such a wonderful live case session, because learning is two-way method, best method, and it is much more effective if it is case-based discussion, so people can understand better way. So I appreciate this effort, and uh, fortunately this morning my fellows are asking, sir, how can you make a comment this severe coronary disease? So I just tell them this morning, you can join this evening program so that you can able to understand how we can make a comment to make a severe coronary disease. Second thing, in examination setting, it is common issue to ask coronary angiogram that is not important in our real life, but real life is much more bigger than exam. Definitely exam is one of the important situation to cross over the, just cross the river, then you can get the highway. So you can practice your life and broaden your life. So thank you very much for this arranging such a wonderful session. I think you should continue this sorts of educational, interactive, case-based discussion, especially in live case. CAG today femoral, next radial, then go for PCI, then go for complex. Then I think it will be much more beneficial for all,
Yes,
not only the
actually,
students. Everyone
Professor
should
Azam,
be benefited.
we came the other way. We started with radial, we did ulnar, we did distal radial. Now we are into femoral. Sorry that you missed. We did not invite you properly.
I have one question, Dr. Ajam.
Right.
How frequently your fellows look to the chest X-ray before choosing the catheter size? How frequent?
It is very, very infrequent, you know. Telling you very, be honest, very, very infrequently. There are some common tips we are discussing. If it is elderly people, if it is especially female, then at least you should go for chest X-ray to understand how the unfolding of aorta or not, how to decide your size. But they become expert after doing some cases. Then they can understand actually what to do. Initially, they don't go for pathologically. Initially, they go for drastically. That's why our educational system is should be reformed.
Yes,
Okay,
thank you.
Professor Fozila, Madam, closing remarks from you, please.
Madam, the line disturb দিচ্ছে।
ম্যাডাম
Catherine.
আনমিউট করতে হবে।
Okay, so probably Madam is in the cath lab or she's out of connection. Ashok sir, remarks from you, please.
Yes, thank you, Dr. Topik. Thank you, Dhimanda. Thank you, Shamim Chaudhary, and thank you all the staff, those who are there, and all the participants. And definitively, I am very much thankful to Professor Ghulam Azam for attending this session. And I think this discussion in their practical life, in their exam, that will be helpful. Thank you, everybody.
So I would also like to thank Professor Azam for making time to be with us and give all those encouraging comments to for Heart Foundation, and also giving the very important tips for our students, which he will be asking when he is an examiner. I would like to thank Dhiman sir for his excellent demonstration. Thank you, Dr. Shamim, Tutul, and all those who are there. I think, sir, we should conclude. Thank you very much. And Allah
Badhujaman
Hafiz.
sir has joined.
Sir, join করছেন? স্যার বদিউজ্জামান স্যার কি আছেন আমাদের সাথে?
আমি আছি, কিন্তু আমি তো কথা বলতে পারবো না, আমি তো রাস্তাঘাটে আছি।
স্যার
আমি তো দেখতে পারবো, আমি শুনতে পারবো শুধু। হ্যাঁ, আলহামদুলিল্লাহ ভালো আছে।
ওকে স্যার,
তোমরা কথা বলো, আমি শুনতেছি।
ঠিক আছে স্যার। সো আমরা স্যার এখন মানে শেষ করছি অনুষ্ঠান। With your permission, sir, we would like to end today's session.
Okay, inshallah.
Okay. Allah Hafiz. Stay safe. Everyone stay safe. Yes.
Allah Hafiz.